Welcome, everyone. It's a real pleasure today to be with a panel of experts, but also of friends. I have the pleasure to chair the session TAVI, Hemodynamic and Outcome. We measuring appropriately, and I'm very, very pleased to have a panel of friends. Um, First, Dr. Philippe Pibaro, we need no introduction, who's going to talk about the discordance between echocardiography and CAT, followed by Dr. Philip McCarty, who actually is an interventional cardiologist, who's going to talk about outcome and increasing gradient. Is there a connection? And then Dr. David Wood, who's going to talk about how to measure appropriately the gradient during potentially increase of gradient versus by CAT versus echo. It's a real pleasure to chair this session. I want to thank Edwards Lifesciences to sponsor this event through an unrestricted grant. So I already introduced my panel of experts. It's a real pleasure to be with friends and experts on this topic. So why hemodynamic after TAVR is so important, and why are we measure appropriately? So as a background, we know that there's a big discrepancy between echo and catheterization, and we saw that clinically on a daily basis. When we put a TAVR valve, we have a good result, and at 30 days or even after the procedure, we have a discrepancy between the echo and the cath. So we're going to explore what will be the tips and tricks to improve the measurements, and also what are the factors that impact the gradient by echocardiogram. We're going to also review the literature with Dr. McCarty about is there any impact on the outcome of these increased gradient. So these learning objectives, first we're going to review the discrepancy between echo and cath. Second, we're going to explore actually how we should measure appropriately the gradient by cath with Dr. Wood. We're going to move on to see if there's an impact on outcome, and then we're going to have a lively discussion with colleagues. So first and foremost, I want to introduce Dr. Philippe Barbaro. Actually, we need no introduction. He's a good friend and colleague, and he was seminal to the VARC theory definition, and he's going to review actually the discrepancy between cath and echo. Philippe, the floor is yours.
Yeah, thank you very much. I do have some disclosure mentioned here. So echo is the primary modality to assess valve hemodynamic function during and after TAVI. Of course, it is important for the initial assessment following the procedure, and eventually to assess the issue of prosthesis-patient mismatch and high residual gradient, and also to follow up on valve function and assess the presence of any dysfunction during follow-up. And also it is used to compare different types of AVRs and different types of valve, of surgical and transcatheter valve. Catheter, on the other hand, an invasive assessment is not yet required and used as a clinical tool, has been used in some contexts to corroborate the measurements of echo. And what we'll discuss today is, are these two modalities, echo and cath, provide the same results, and do they measure the same thing? And before getting started into that, it is important to understand why we do that. Why we measure the hemodynamics, the gradients, and prosthesis-patient mismatch, and by echo or cath. This is eventually to identify, to detect as early as possible a bioprosthetic valve dysfunction. And that there are different types of bioprosthetic valve dysfunction that needs to be identified, and VARC 3 document is very clear about this, and that will be published soon. There are the non-structural dysfunction, which essentially include prosthesis-patient mismatch, because prosthesis-patient mismatch is a valve that is functioning normally, but it is too small for the patient, so high residual gradient there. Paravalvular AR is also a non-structural valve dysfunction. And in this case, the abnormality, of course, occurs at the time of the procedure and then remains stable over time. Then you have the structural valve dysfunction and the structural valve deterioration, where there is intrinsic permanent change to the leaflet or the stent of the prosthetic valve, and which eventually lead to a deterioration in the hemodynamic function and eventually a bioprosthetic valve failure requiring reintervention. So also, as a separate category, we have the thrombosis and endocarditis, because this, of course, this complication may lead to deterioration in hemodynamic valve function. Sometimes it is reversible. Sometimes, unfortunately, it becomes permanent and irreversible. The measurement of this transvalvular gradient and AOA is key to assess the valve hemodynamic function and identify bioprosthetic valve dysfunction that we just discussed following TAVI. And when you have an elevated, a high residual gradient post-TAVI, well, the question, what is high residual gradient? Well, according to valve 2 and valve 3 will be the same as a mean gradient more than 20. Then you wonder, is it a dysfunction, a stenosis of the valve? In which case, of course, there is a matter for concern due to thrombosis, carditis, or structural valve deterioration if it's at a longer follow-up. Or it is prosthesis-patient mismatch. Or is it due to echo versus CAT discordance and difference? And this is what we will discuss. So this is the first case, an 82-year-old man who underwent actually a transfemoral TAVI valve in valve. So within a failed bioprosthetic valve with a 23 millimeter sapien XT. And we got actually this is a case that is a courtesy for my good friend Abbas. And they did simultaneous CAT and echo gradient. So you see the echo shows during the procedure a mean gradient of 16, but the CAT shows almost no gradient, 2 millimeters of mercury. So there is an important difference. Of course, in both cases, the gradient is not that high, so there might not be any reason for concern. But if you go to the next case, then a 79-year-old man with a failed bioprosthetic valve again a transfemoral valve in valve TAVI, but here with a smaller valve, a 20 millimeter sapien 3, because this was a small surgical bioprosthetic valve. And here the gradient by echo was 40. So this is very high residual gradient. And then you may wonder, is there any dysfunction, issue with this valve in valve? And on the other end, at the same time, by CAT, by invasive measurement, you got a mean gradient of 11. So there is here a major discrepancy, major discordance between echo and CAT. So why do we have this discordance? So first, what you have to know is that, well, as you know, we use the Bernoulli formula to calculate the pressure gradient by echo. This is the way to estimate the pressure difference from the velocity that we measure by Doppler. And if you look at the original Bernoulli formula, it is pretty complex and has several components. And here you see there are actually three main components in the Bernoulli formula. We have the convective acceleration, the flow acceleration, and the viscous friction. And for clinical use, we do a simplification. It's not a simplification, it's an ultra simplification. So we neglect the flow acceleration, we neglect the viscous friction, and we end up with this convective acceleration remaining. But what we do further, we also in the convective acceleration neglect V1, so the velocity pre-prosthesis, to finally end up with this very short abbreviated version of the Bernoulli formula, where now it's only 4 times V2 squared. So this is, of course, one of the reasons why we may have some discordance between CAT and echo. The other thing is that the Bernoulli formula assumes a laminar flow and no turbulence. As we just said, it neglects, for clinical use, we neglect actually 4 times V1 squared, so the pre-valvular velocity. It assumes also a straight and relatively short tube, which is not necessarily the case in a human heart. And it does not take into account the pressure recovery. So that's all the assumption we do to apply the Bernoulli to the clinical context. And of course, several of these assumptions may not be met. So the other source of discordance is the pressure recovery. So besides the Bernoulli formula, where we have several assumptions that may not be met, we also do not necessarily take into account the pressure recovery. So what is pressure recovery? Well, when the blood flow contracts to pass through a stenotic valve or through a prosthetic valve, well, there is an acceleration of the flow and a pressure loss. And then downstream of the valve, the flow jet re-expand, and there is some portion of the kinetic energy, so the flow acceleration, that is reconverted back to pressure. So we have some pressure recovery that is here. Of course, the pressure recovery is not complete, and we are still losing some pressure at the level of the valve, especially if the valve is stenotic. But we do recover some pressure. The problem is that actually Doppler is measuring the velocity where it is the maximum at the level of the vena contracta. So it will really measure the pressure gradient where it is the worst. Whereas the catheter is measuring the pressure a few centimeters downstream the valve, downstream the vena contracta in the ascending aorta. So after pressure recovery. So, and this is the main message today, is that Doppler echo and catheter do not measure the same thing. And Doppler echo does not account for the pressure recovery, whereas catheter does. And this is not a new concept. I mean, these are all studies showing the difference between cath and echo. Cath measuring systematically lower gradients than echo. This is for native AS. Again, here for native AS. And then another study that is from 2000 from our group, where we simulated native AS in an in vitro pulse duplicator, and also we put prosthetic valves and bioprosthetic valve, and these are the square that you see here, and we have the same phenomenon. So this pressure recovery occurs following native valve, following prosthetic valve, following surgical valve, and following transcatheter valve. And the pressure recovery for a given prosthetic valve, a given cardiac output, a given stroke volume will be more important if the size of the aorta is smaller. This is a well-known phenomenon. And so really the magnitude of the pressure recovery, and so the discordance between cath and Doppler will depend on this interaction between flow, the prosthetic valve airway, and the size of the aorta. So this is a case that illustrates this concept, where actually you see you have a pressure in the left ventricle of 200, and then there is a gradient measured by Doppler of 60. So this is the pressure loss between the left ventricle and the vena contracta, so immediately after the valve. But then there is some pressure recovery of about 20 millimeters of mercury. And so the net pressure gradient, the difference between the ventricle and the ascending aorta, is 40, not 60 as Doppler would estimate. And so, and the pressure gradient that is relevant from a pathophysiology and clinical standpoint is the net pressure gradient, not the pressure gradient at the level of the vena contracta that would measure by Doppler. This shows in this case that we have a difference of about 20 between the two modalities. So this summarizes the factors that may account for the echo-cath difference. There are the assumptions with the Bernoulli formula, and that underlie the ultra-simplification of the formula, where we finally have a formula that is much more complex and granular and comprehensive, and we finally end up with a 4 times V2 square. This is one source, one of the reasons for the difference between echo and cath, and the other main reason is the pressure recovery. So is this difference or discordance between echo and CAT similar for all type of aortic valve? No. Actually, if you look for native AS, this is severe native AS, well, you do have a difference, okay? That is absolute term may be substantial. For example, here you would measure 52 millimeters of mercury by echo versus 40 by CAT. So this is a 12 millimeter absolute difference, essentially due again to pressure recovery and Bernoulli formula. But it doesn't necessarily change the grading of AS severity per se. So in absolute term, yes, there is a difference. In percent and relative term, it is not that clinically relevant. When you go into the native TAVR, well, you see that you have in absolute term, it is a smaller difference, but in percent, it is different. You have 7 by echo, 2 by CAT. And where it is maybe the more pronounced, it is for the valve-in-valve. In the valve-in-valve TAVR, this is where we see the most important differences between CAT and Doppler, and where we often have actually high residual by echo, and when we corroborate by a catheter, there is actually very little or no gradient. The other thing and question is there any difference in the difference between echo and CAT according to the type of transcatheter valve that we use for TAVI? So essentially balloon expandable versus self-expanding. There is still some uncertainty regarding this issue, but in this elegant work, again led from Amr Abbas, the subset of TAVI where he found the most important difference was in the small balloon expandable valve. This is really where, in the small balloon expandable valve, where Doppler was measuring a much higher gradient than with catheter. In the other type, well, there was some difference in the other categories. So the large balloon expandable valve and the small and large self-expanding, there was still some differences because Doppler will always measure higher gradients, but the difference was not as important and maybe not as clinically relevant. This is a recent study that we did. This is in vitro, so this is in vivo, so there are some limitations as well, but at least in vitro, we can better control the different potential confounding factors, the cardiac output, the aortic compliance, etc. And what we saw actually, again, and here this is what is showing here is really the difference between echo and CAT. And actually, this difference was always present, but this was actually similar in self-expanding versus balloon expandable, except in the low flow state. I will go rapidly over the valve tree definition for bioprosthetic valve dysfunction and bioprosthetic valve failure because we are running out of time. Just to say that what we put in valve tree and the papers in press, and Philippe Généreux led this valve tree work, is that we to eventually define structural and hemodynamic valve deterioration, we put a very important emphasis on the morphological, the structural changes, and then for defining stage 2 and 3, so moderate and hemodynamic valve deterioration, we mandated the deterioration in hemodynamic function, so an increase in gradient with concomitant decrease in airway with the following cut point values. The main message here is that echo gradients are higher than CAT gradients because of the unmet Bernoulli assumption and because of pressure recovery. And what we have to, I think, take as a take-home message is that echo and CAT do not measure the same thing. So we should not expect to get the same result. And the echo CAT gradient differences or discordance are more important in TAVI versus in native AS for sure, and in valve-in-valve TAVI versus native TAVI. And eventually, this discordance may be more important in the small balloon expandable TAVI as we saw. So I think in terms of clinical implication, first, an echo gradient more than 20, mean gradient more than 20 by echo should not be considered as bioprosthetic valve dysfunction. And identification of dysfunction, so intrinsic problem with the valve, should be based, according to valve tree, on evidence of structural changes to the leaflet or stent, and hemodynamic valve deterioration. So more than the absolute value of gradient or AOAs, what is important is delta during follow-up, is a decrease, is a deterioration. And echo will remain the primary modality to assess valve hemodynamics during and after TAVR. We're not going to cut the patient for follow-up. So we'll still use echo, but I think we have to learn how to use and interpret the echo findings. But if on the other end we have an elevated gradient on echo, well, I think we should corroborate this finding by categorization during the procedure before eventually considering additional measures and techniques such as balloon postulation or stent fracturing. Thank you very much for your attention.
Philippe Pivaro, excellent review again. I cannot stress enough your role in VARC3, and thanks for a pristine presentation. Now it's my pleasure to introduce another Philippe, Philippe McCarty from King's College in London, who's going to talk about is there a relationship between hemodynamic after TAVR and clinical outcome. Philippe, the floor is yours.
Thank you very much, Philip. It's a seminar of Philips today, so three of us are called Philip. It's easy to remember our names. So thank you very much to the organisers for asking me to contribute, and also for Philippe for starting and raising the bar very high with an excellent talk. Now, it's my job today to talk about haemodynamics, which have had a nice, elegant introduction, and clinical outcomes. Here are my conflicts. Now, my first disclaimer is that actually I'm a structural interventional cardiologist. I'm not an echo specialist, but it is fair to say that I base an awful lot of clinical decisions on echo parameters. So they are fundamental to my practice as a structural cardiologist. The first question I'm going to address is, are the echo-derived gradients that Philippe has introduced us to important post-TAVI, both acutely, immediately after we deploy the valve, and in the longer term? Certainly, as we've heard, VARC implies that they are. Is there any clinical data to support this? Let's look at some of the clinical data that's available to us. So the VARC2 definitions we've heard about already suggest that a single absolute mean gradient above 20 millimeters of mercury is considered to be a dysfunctional valve. But we've already heard that that may be not telling the whole story. If we go to VARC3, again introduced to us, we learn that structural valve deterioration is defined by a change in the gradient of 10 millimeters of mercury, or an absolute mean gradient of greater than 20 millimeters of mercury. So let's just explore whether some of these things maps to clinical outcomes. And we'll look at the acute phase first of all. Should we as TAVI operators be disappointed if we get an immediate post-TAVI gradient of 20 millimeters of mercury? Well, the data suggests that we shouldn't, and in fact, even suggests the opposite. So this is data from the TVT registry looking at SAPIEN 3 TAVI procedures. And you can see that the survival out to 12 months in those patients who have a gradient of greater than 20 is actually better than those patients who have a gradient less than 20. So that would certainly not support this leading to adverse clinical outcomes. If we look at a multi-center retrospective study using all valve types, not just the SAPIEN, you can see the same thing. It certainly seems that if we look at clinical outcomes and cumulative survival, there does not appear to be a relationship between the mean gradient. In fact, again, this graph shows the opposite, whereby patients with a greater gradient seem to be doing better. If we look at the subset of patients who have already been alluded to in the first talk, the valve-in-valve patients, these are patients that quite often have quite a high gradient after TAVI procedure. And again, you can see that those patients with a mean gradient over 20 and those with a mean gradient less than 20 appear to have similar clinical survival. And this shows a similar phenomenon. This is data again from the TVT registry, looking at patients with small valves and small annuli. And you can see there's the group on the left, 20 millimeter annulus, and those on the right is more than 23. And it's not surprising to see that the small annulus patients have a higher mean gradient, and a higher proportion of them meet the definition of severe patient prosthesis mismatch. And yet, looking at all-cause mortality out to 12 months, there is no difference between these two groups of patients. So what about differences between the various TAVI devices? We know that different TAVI devices give different gradients. So does that map to clinical outcomes? Well, if we look at the Ocean TAVI registry, again, the answer would appear to be no. In this registry, the investigators looked at patients with a very small annulus, less than 21 millimeters, and a small annulus. You can see the less than 23 on the left panel and less than 21 on the right. Now, this was a study that compared the Evolute with the Sapien in a real-world style. It was a registry study, and you know that on the left you can see that the gradient is higher with the Sapien, and this is even more marked in the patients with a very small annulus of less than 21 millimeters of mercury. And yet, in the lower panel, you can see that actually the survival in these patients did not map with this residual outcome. And in fact, despite this change in echo gradient, the mortality was higher with the Evolute than it was with the Sapien. If we look at the Portico IDE study, the same sort of phenomenon occurs. You can see that on the left-hand panel, the Portico is compared with the Evolute valve. Again, there's not much difference in the mean gradient here, yet the mortality was about the same. That would fit. But on the right-hand panel, Sapien 3 and the Portico, the Sapien 3 did have a slightly higher mean gradient after the procedure, and yet the mortality was significantly lower with the Sapien than the Portico. So certainly in these studies, it does not seem that the valve type and the gradient that each valve type creates maps to clinical outcomes. So what about echo-derived gradients in TAVI valves versus surgical valves? And let's look at some of the randomized trials here. We know that usually the residual gradients after surgical valves are higher than TAVI valves. And we also know that, and we've been taught that severe patient prosthesis mismatch in the surgical population is a bad thing. There's 3 studies I'd like to take you through here. The first is the NOTION randomized controlled trial. And this was a study looking at TAVA versus SAVA. And you can see here that the surgical mean gradient was a little higher, right out to 60 months, yet the survival was no different in the 2 groups. If we look at the Evolute low-risk trial, you'll see a similar sort of phenomenon. So the Evolute low-risk trial compared Evolute TAVA with surgical AVR, and surgical residual gradients are a little bit higher, yet there was, if anything, a trend to better survival in the TAVA group, and we know this data very well. And a similar phenomenon occurred in partner 3. We look at partner 3 data, you can see that actually in partner 3, the gradient was a tiny bit higher in the TAVA group with the Sapien, yet we all know the results of partner 3, and the survival was actually better in the TAVI group. Let's now turn to patient prosthesis mismatch. Now, in the surgical literature, as I've said, we're taught that PPM is a bad thing and correlates with worse outcomes. Does this apply to the TAVI population? Well, initially, we thought that it did, and this slide shows, again, data from the TVT registry. This is a slide showing, again, data from TVT, which showed very, very large numbers. And it would appear from this study that severe PPM led to an increased mortality. But this was a study that had no echo core lab and was criticised with an accompanying editorial from one of our panel members here today. We look at some other data on PPM. Let's see if we can see a correlation between gradient and real-world clinical outcome. Well, this is data from the partner study, and you can see on the top panels the surgical cohort, and in the lower panels you can see the TAVI cohort. And you can see that with the surgical patients, PPM does map to a worse outcome. There's a higher mortality in patients who have a defined patient prosthesis mismatch. Yet in the TAVI cohort, that is not the case. And indeed, if you divide the patients into no ppm, moderate and severe, it almost looks the wrong way round, with patients doing best in the severe ppm group in the TAVI cohort. A similar phenomenon is noticed from this data. This is short-term data from the TVT registry using the SAPIEN 3 data, but again, patients who have defined severe patient prosthesis mismatch don't appear to do any worse across 12 months than patients without PPM. Now, this is data from Abbas, and this study was alluded to in the first talk. This is data using all TAVI devices, not just the SAPIEN, again looking at patients with defined severe PPM and no PPM out to 24 months, and there is no difference in cumulative survival in this TAVI study. And lastly, I'd like to just take you to this data. This is data from the Partner 2 S3I sub-study. The definition of PPM is often criticized because of the way that it's derived. And we've heard that from our first talk today. And some people feel that if you define PPM using CT data rather than echo data, you get a slightly more refined definition of patient prosthesis mismatch. But that does not appear to change this lack of correlation between PPM and clinical outcomes. You can see here on the left graph that, again, severe PPM by echo criteria and on the right side, severe PPM by CT criteria do not appear to correlate with mortality. So it doesn't appear to be the way that we're defining PPM or the way that we're measuring PPM, but it is certainly something to do with our echo measurements and the way that we're defining these echo gradients. I'd like to finish just on talking about different patient populations, and it's worth being aware that in certain patient populations, PPM can be influenced and can be different. For example, in the elderly, it is thought that PPM tends to impact less so than in younger patients. And it was in fact for this reason that the TAVI data was first explained. It was thought that TAVI patients were older and therefore PPM is not as relevant. However, that wouldn't explain the differences I've seen in the randomized trials. Also, in obese patients, there tends to be an overestimation in patient prosthesis mismatch with a lower indexed EOA. And then there are patients with a low flow state who get a pseudo-severe EOA index, and you get overestimation in PPM. So I think particular caution is needed in these three patient groups. So in conclusion, I think we can say that elevated echo-derived gradients have been assumed to correlate with what was thought to be a poor procedure outcome, and certainly VARC2 and VARC3 would infer that. Yet elevated echo-derived mean gradient immediately post-TAVI is not correlated with clinical outcome on quite good data that I've shown. And also the higher rate of echo-defined patient prosthesis mismatch in smaller TAVI valves doesn't appear to correlate with a poor clinical outcome. Differences in the post-TAVI implant gradients with different devices, again, don't correlate to clinical outcome and differences in medium-term survival. And patient prosthesis mismatch post-TAVI, whether you define it with echo or CT, does not appear to correlate with survival. Thanks very much for your time.
Philip, thank you so much for this great presentation. Now is my real pleasure to introduce my friend and my Canadian fellows, David Wood, who's on behalf of his team, including Janar Satanantan, will present how to optimally measure a gradient by CAP. So David, thank you so much.
Look at that. They used a picture of me. I look about 18 years old, Philippe. Also, I don't think I've ever had a presentation where I had such close friends, a Philippe, and a Philip. I feel left out and like I need to change my name. So disclosures, and we are presenting on behalf of our colleagues. So agenda, evaluating what's currently being done. How should we measure? A couple of case studies and future directions. This has become an incredibly important topic for us here in Vancouver with myself, John Webb, Janar Savanathan, but also the complete TAVR group with 103 North American sides, and now the discordance TAVR group with Philippe Pibereau, Amar Abbas, and others. So this really has gained momentum over the last 12 months. So where did this start? Over a year ago, routine TAVI day in Vancouver. We are doing a next generation device that hopefully will see the light of day in a few years. And we get an echo gradient on the table of 15. We do meticulous invasive gradients, and we end up with a echo gradient, a little bit of a delay there, of only, or an invasive gradient of only 4. And so we have the engineers from Irvine, California. I think there was 20 people on the call. And when we saw the echo gradient, there was lots of discussion. Did we need to go back to the drawing board with this new next generation balloon expandable device? But when we did the invasive gradients, everyone was very happy and opened bottles of champagne and all of this. So this led us down this rabbit hole with Amar Abbas and Philippe Pibereau and others on what exactly are we measuring.
Hello, everyone. It's a great privilege to speak to you on this very important topic. And David nicely laid the scene there. And what you've seen on the slide, I think, Dr. Pibereau already outlined in great detail and really highlighted some of the key differences between how we derive these measurements, both on echocardiography and also invasively, and some of the limitations that can arise from simplification of some of the concepts such as the Bernoulli equation when you transfer that to a valve that's now functioning normally in the setting of a transcatheter heart valve. So what you can see on the screen here is some work that Amar Abbas has really led, trying to highlight and educate the field on this potential discordance that can occur between echocardiography and invasive gradients. And certainly by no means is invasive gradients a replacement to echocardiographic derived measurements. It's merely potentially a tool that could be additive and useful in the follow-up of patients with transcatheter valves. So you can see from this work that in about half of the patients, there can be a discordance of 5, and in a small subset of patients, 10%, it could be even as greater than as much as 10 or more in terms of the discordance. So I think in general, in terms of current practice, we rely very heavily on echocardiography, as we should, because it is a reliable modality that's easily available and non-invasive. And, as Dr. Pibereau outlined, VAC3 highlights that it's not just about looking at one metric, but really it's a holistic and complete assessment of the valve in order to better understand whether it's degenerating. But when you look at the real world, and certainly all of us have seen this in our transcatheter heart valve clinics, the referring community or caring cardiologists often rely a lot on mean gradients. And we certainly in our local practice see a lot of referrals back to us purely for concern about an elevated gradient. So I think for us, what we've seen locally, and certainly what David will highlight from some of the sites from the discordance TAVR study that he will just outline, is that we really had to evaluate our own approach as to how we do this technique. I think it's become clear, and when you look at your own labs, I'm sure we would all admit that how leveling and zeroing is done is performed variably. Quality maybe is an issue, and certainly we know that even just changes in technique can impact the values by as much as 8 or more, and that's been shown. So what are the practical implications? Well, I think, David will often say that doing invasive hemodynamics badly is worse than not doing it at all. And I think that's a key point, is that you want to try and make sure that there's an approach that's standardized, reproducible, and of very high quality. And it's going to be really important as we try and look at ways to integrate invasive measurements into the follow-up of patients with transcatheter heart valves. And so with the key point being that we want to understand what the true function of the valve is, and also more importantly, whether there are further therapeutic intervention needs to be done for a valve that may be potentially failing. So this is an algorithm that we have implemented in Vancouver, and David will show you very shortly some of the preliminary results, and then also looking to next steps in terms of multi-center experience. But just to highlight that question I brought up from a clinical perspective, that when the gradient's over 20, these patients may be referred back to us. But more importantly, we also wanted to look at patients that meet VAC3 criteria for at least stage 2 or more of moderate hemodynamic valve dysfunction. All these patients undergo a cardiac CT to exclude the presence of valve thrombosis. And then in our center, They actually all come back for invasive gradients using standardized invasive hemodynamics that David will go through from a technical perspective about how that is performed. But if patients have concordance, then we consider reintervention either with surgery or more commonly with redo TAVR. And if there's discordance, then usually that's because the invasive gradient is lower, and typically we just follow these patients up with routine clinical follow-up.
Look at that. We miraculously came back on here so you can see what's happening. So we've spoken at PCR meeting, we spoke at STS meeting. Obviously, this is a wonderful meeting with Nicholas Van Meegen and others. I think it's a wonderful opportunity. So we're going to look at some long-term things with 2 large prospective RCTs. But in the short term, as Janar said, I think doing hemodynamics properly, which we all learned and have done intermittently for many years, really can be done very efficiently. We're all about efficiency here, aortic mitral tricuspid with John and myself in Vancouver. You can get very nice hemodynamics in under 4 minutes, both immediately post-TAVI implant, as well as if you're bringing someone back long-term, 1 month to 10 years later. 2 pigtails, 8 tracings. I'll show you a couple of examples. This is what they've implemented both for complete TAVR with 103 North American sites, as well as discordance TAVR with 11 sites globally. A kissing pigtails. Again, this is just to assess, make sure your systolic is within 2 millimeters of mercury. Everything is zeroed and leveled. We actually come up with a CT-derived height from your CT scan, which we all do pre-TAVI, so we know where to set your transducer on your table. Very easy, very quick. We cross. And again, because we're looking at pressure recovery and these different THV frames behave differently immediately above the valve frame, we do 3 measurements, 10 seconds each, 5-second flush right above the valve, 1 centimeter above. The other pigtail is as deep as possible without causing ectopy. We repeat it so that you're up at the transition from the ascending aorta to the transverse arch, 3 measurements. Often if we see pressure recovery, it's in the order of 2 to 3 millimeters of mercury, not the large calculation you're going to get if you just use a pressure recovery formula for adjusting your echo piece. We then come back and do a pullback and have kissing pigtails at the end to make sure there's been no drift. If you're doing immediately post-TAVI, you don't need to do the kissing pigtails pre if you set up your monitors and your manifolds correctly. In that case, you would just do the kissing pigtails post. And this literally takes less than 4 minutes to obtain. And if you're going to be doing hemodynamics anyway, and you have an on-table echo, why not do them correctly? So TAVI in 2017 at age 57, lots of comorbidities, NYHA2, factorial, BMI greater than 45, CT, again, no valve thrombosis. What should we do? The gradient goes from 16 to 9 to 28 to 27. This is a young patient. Our decision has very significant implications. I would argue that at some centers, they might say the gradient's now 27. Maybe we should think about redilatation or perhaps even a valve-in-valve. We brought the patient in for invasive hemodynamics using the approach we just outlined, and the mean gradient was 18. We have a CT showing normal function, no valve thrombosis. This patient we're just going to follow normally, so reclassified to normal THV function. Case 2, an 82-year-old post-valve-in-valve TAVR. We put a 20 millimeter Sapien 3 in a failed 21 millimeter trifecta. Multifactorial NYHA2 with COPD, no valve thrombosis on CT. Gradient goes from 17 to 46. And we've learned, again, in the smaller prostheses and especially in valve-in-valve, that we can see some very high gradients post. What does this mean? We brought her back, and you can see here, invasive gradient is 19. CT, no mischief going on with the valve, no valve thrombosis. We would say that she has been reclassified to normal THV function. So some preliminary data. I don't know how well this shows up, but our initial 13 patients as part of the pilot study, we now have more than 20 in Vancouver, ranging from 1 month to 10 years post THV. All of them with a gradient over 20. You can see in the 13 with a gradient over 20, most are reclassified below 20. But I think the most important part here, for the 5 patients that actually met VARC3 criteria for hemodynamic valve dysfunction, all 5 could be reclassified if you substitute an invasive gradient, versus the echo-derived gradient. We can talk about that in the discussion if there's time. I know the overall is running a bit late. So, future directions. Two pieces here, complete TAVR and discordance TAVR. And I know, Philippe General, you'll like those logos, my friend. I know you like logos. So, for complete TAVR, on behalf of all of our co-investigators, Marty, Roxana, a whole bunch of wonderful people throughout North America, we've added in complete TAVR, 4,000 patients, 103 sites, 2,000 randomized post-TAVI to stage PCI, 2,000 randomized to medical therapy, followed for a median of 3.5 years. We've added in the hemodynamic assessment. That's how important John, myself, Marty, Roxana, others feel about this topic. So you can now see in the flow diagram, I won't go into details here, severe aortic stenosis patients, they have a 70% stenosis in a coronary artery. All 4,000 undergo transfemoral TAVR, balloon expandable. They're then randomized within 96 hours to either medical therapy or stage revascularization. They're followed for 3.5 years, powered for hard endpoints. What we've done is we've added in a hemodynamic piece. All 4,000 patients have hemodynamics, what we just said with an on-table echo at the beginning. That is then transferred to our core lab. We've actually created a hemodynamic core lab in Vancouver, which I think is crucial. They're followed for 3.5 years. At any time during that period, if the gradient goes over 20 or they meet VARC-3 criteria for at least moderate hemodynamic valve deterioration, they will come back for an on-table echo and invasive hemodynamics. We also have a 300-patient sub-study looking for the patients that are coming in for their stage PCI at 45 days, doing repeat hemodynamics there. So I think this will be a gold mine of information. For discordance TAVR, this is our study, 11 sites. We've enrolled 21, I guess, so far. We're aiming for 50 TAVI valves, 1 month to 10 years post, coming in for invasive hemodynamics, looking at similar metrics with regards to PPM, pressure recovery, the difference between the echo-derived and the direct invasive measurements. I think this, again, will be a gold mine of information. So in my final piece here, echo will remain an important tool. Clinicians must be aware of the potential discordance between the two, new terminology. Standardized invasive hemodynamics will be crucial for both acute and long-term management, and ongoing studies like complete TAVR, 3.5-year follow-up. We'll have the results in 2026, but hopefully that 300-patient pilot study sooner, as well as discordance TAVR, which we hope to have results later this year, 50 patients, 1 month to 10 years post-TAVI with elevated gradients, either just the gradient or VARC-3 criteria for moderate valve dysfunction, I think are going to be very helpful on how we should treat our patients when they come back with abnormal echocardiographic parameters and a CT showing that there's no valve thrombosis. Thank you so much, my friends, on behalf of everyone here in Vancouver, the Center for Cardiovascular Innovation, and the university. Thank you so much.
David, Janard, thanks for such a great presentation. We're going to have exactly 6 minutes for this discussion. I want to start quickly with a question. And I believe that these presentations were pretty reassuring when we have an elevated gradient, very reassuring to see that there's no impact with outcome. And actually, when we compare to CAT, the gradient is not that elevated. One quick question I have for Philippe Pibaro, and maybe we can expand to the rest of the panel. When you see an increased gradient at 30 days, let's say 18, is there anything else at the echocardiogram, practically speaking, that can help you to decipher what I will say a malign increase in gradient versus a benign gradient? Because I would love to see the echo better to decipher what is a benign versus a malign increase in gradient. So I'm going to open with you, Philippe Pibaro, and then maybe David and Philippe can comment after.
So yeah, that's a great point, Philippe. I think I will make a short answer is there are two things I'm looking at. When I have a change in gradient, I also look at the concomitant change in valve area in AOA and Doppler velocity index, because typically what you see some increase in gradient early after the procedure, but it is related to an increase in flow more than a malignant increase in gradient. The early function is improving because of the release of afterload, and therefore you have some increase in flow. The gradient will increase because the gradient is flow dependent. But the valve area and the Doppler velocity index also increase. And it's a different situation if you have an increasing gradient with concomitant decrease in valve area and Doppler velocity index. The second thing that is very important to look at echo is the leaflets. Look at the leaflets. If the leaflets look pristine and have normal morphology, there is no evidence of thickness, and mobility is normal, then it's not a dysfunction of the valve. And if you have a doubt, then my threshold to do a TE or other modality is pretty low.
David and Philippe, do you use, most of the time I have BNP in clinic, there's no increase in BNP, patient feels great, and then you have this gradient of 15 and you say, okay, what I'm doing. So David, what is your take on that? You use a NT-proBNP, do you use MRI, do you use other to confirm that the gradient is not malign, it's just an artifact by echo?
So yeah, wonderful question, and I think Philippe is absolutely, as usual, right on target. I think going to either a serological test like BNP or a CT to ensure that there is no mischief with the leaflets, in addition to the echo, is crucial. I think what we've learned over the last year is that just having an echo gradient over 20 often is a trigger for referral base to do further investigations. But the reason we added in the VARC3 criteria for moderate hemodynamic valve deterioration is we really wanted to put some scholarship around that. And so I think having 4,000 patients prospectively followed for 3.5 years, Philippe, having the 50 patients come back up to 10 years post-THV with elevated gradients and meeting that VARC3 criteria is going to be incredibly helpful to you and I, Philip, and others at the bedside and in our THV clinic on what we should actually be doing with these patients. For now, we're using that algorithm. We're carefully looking at not just the mean gradient, but the other changes as per VARC3. But I think this is an evolving area and a very exciting hot topic within TAVI, my friend.
Perfect. I want to direct a question to Philippe McCarty, and we can close. We have 1 minute. And you mentioned a very important question about the young patient. And in terms of valve selection in this gradient business of increase about 15 or 10, how do you factor in actually all the other, I would say, complication in valve selection? It seems that you should have an hierarchy of complication where you have death, stroke, PVL, pacemaker, and coronary access. How do you select the perfect valve for a young patient? And it seemed that for me, this benign increase of gradient should be very low in the list of the hierarchy of complications. So Philippe McCarty, please educate us how you choose a valve in a young patient.
Yeah, in such a short time. Well, I think everything that's been said tells us that you shouldn't hang your hat on a single metric. You need to assess the patient in the whole, and you need to assess the echo in the whole. We find looking at the leaflets really, really important in terms of this post-TAVI assessment and using serological markers like you say. But in terms of trying to select before you've done the TAVI, I don't think that the difference in gradients it makes any difference to me. I think the clinical data that I showed in my talk illustrates that actually this echo-derived gradient is a little bit flawed, and I think we need to get this data that David talks about, a very exciting study, so that we can understand it a bit better. I think if there's one take-home message from this, it's that we shouldn't read too much into this echo-derived gradient. We need to assess other things and look at other things in the patient as a whole.
Yep. So perfect way to end this webinar. So I want to thank my panelists, Philippe, and David, and Janar. Thank you for Edwards Lifesciences for the support of this webinar. And I think we learned actually that we have to be careful with the echo to confirm with the catheterization and that there's no real impact on outcome. So thanks again for being with us. Thanks to TIO for letting us doing this webinar. And please, hopefully we're going to see you soon.
Thank you very much.